Good afternoon and welcome to today's PQA Quality Forum Webinar on Pharmacists Conducted Immunization Assessment and Documentation. I am Richard Schmetz, PQA's Senior Director of Communications and moderator for today's forum. As we get started, a quick logistics reminder. Use the questions feature in the webinar control panel to send us your questions throughout today's event, and our speakers will address those at the end of their presentations. Today's event is being recorded. A copy of the slides and audio recording will be available in the PQA Member Resources Library later today. And at the end of the forum, we'll have a quick survey for you to provide your feedback on today's event and your suggestions for future forums. I want to begin by thanking PerformRx. PerformRx is an educational sponsor for this quality forum. Thank you to PerformRx for their support of PQA today and throughout the year. You can learn more about PerformRx at performrx.com. I would now like to introduce today's presenters. Simon Anderegg is a clinical systems analyst at DocStation and pharmacy HIT collaborative liaison. Simon also has a background in inpatient nursing. Megan Gabriel is PQA's Director of Measurement Science and Analytics. She is responsible for measure testing, analytics, and research to support the measure development and implementation process. And Mel Nelson is Director of Program Management for the PQA Performance Measurement Team. She is responsible for championing operational excellence and continuous process improvement. So I will now hand things over to Megan Gabriel, who will get us started.
Thanks so much, Richard. So I'll go through the background and then I'll pass it over to Simon, who will talk about the methods, and then we'll hand it over to Mel Nelson, who will speak about the findings and the implications of this project. Immunizations are not just for children. Protection from some childhood vaccines can wear off over time. Adults may also be at risk for vaccine-preventable diseases due to their age, lifestyle, or health conditions. All adults need immunizations to help them prevent getting and spreading serious diseases that could result in poor health or missed work, medical bills, and not being able to care for their family. In short, vaccines can lower our chances of getting certain diseases. For example, the hepatitis B vaccine can lower our risk of liver cancer, and the flu vaccine can lower our risk of flu-related heart attacks or other flu-related complications from existing health conditions such as diabetes or lung disease. Vaccine-preventable diseases cause long-term illnesses, hospitalizations, and even death. And there's a national focus on adult immunization rates. The Advisory Committee on Immunization Practices, or ACIP, is a committee within the CDC that was established a long time ago. It was established in 1964 to provide guidance and advice on effective control of vaccine-preventable diseases. Public and private insurers use ACIP recommendations to determine which vaccines they'll pay for. And the National Vaccine Advisory Committee, or NVAC, was established in 1987 to recommend ways to achieve optimal prevention of human diseases through vaccinations. They also provide direction on how to prevent adverse reactions to these vaccines. So they emphasize the importance and need for providers to not only assess patients' immunization status during every patient encounter, but also recommend needed vaccines, administer vaccines, or refer out to another provider, and also document the receipt of those vaccines. And as one of the most accessible and frequently visited healthcare team members, community pharmacists are uniquely positioned to improve immunization rates, particularly during medication therapy management or MTM services. MTM is a term used to describe a broad range of healthcare services that are provided by pharmacists, who are the medication experts on the healthcare team. Core elements include medication therapy review, medication-related action plans, intervention, referral, and documentation and follow-up. This important combination of professional activities and responsibilities are within a licensed pharmacist's scope of practice. The pharmacist can not only assess their patient's immunization status, but also document that the assessment has occurred. MTM services may be provided directly to the patient or, in some situations, to the caregiver or other persons involved in the care of the patient. It's been shown that by routinely asking patients about their immunization history, it can lead to increased vaccination rates when there's an identified gap. So by using standard assessment practices of patients' immunization status during an MTM service, pharmacists have the improved ability to administer needed vaccines or make, as needed, referrals to another provider for vaccine administration. For pharmacists to document patients' immunization status and to determine compliance with ACIP standards, MTM vendor organizations need a technology infrastructure within their platforms to meaningfully capture these data. This proof of concept was designed to be a scalable model for immunization-related MTM services. To align with healthcare industry standards, SNOMED CT codes, along with RX norm and CVX codes, were updated and used to accurately capture a patient's immunization status. However, currently, there is no standard practice for assessing and documenting patient immunization status during a pharmacist-provider MTM service. Because of that, development and implementation of a standard method to evaluate and improve pharmacist performance in this area has been quite challenging. PQA has drafted 2 quality measures that aim to improve adult immunization rates. However, until this proof of concept, the infrastructure to capture necessary data elements were lacking. And so before I turn it over to Simon, I just wanted to take just a moment to kind of talk about the setting. And as previously mentioned, the primary objective of this proof of concept study was to develop the infrastructure needed to routinely conduct immunization status assessments and document compliance during MTM in the community pharmacy setting. Secondary objectives, including using that infrastructure to examine the 2 draft immunization quality measures. So they measure both assessment and compliance, as I mentioned, to identify gaps in immunization status. This project was conducted in partnership with DocStation with support from Merck. The study setting included patients within the DocStation platform that were covered by a health plan in the Midwest. Specifically, this proof of concept included 258 pharmacies. 5 of those were regional chains and had at least 10 stores, and the remainder were independent pharmacies. And the project also incorporated and evaluated 2 of PQA's draft immunization measures, so both the assessment and compliance. And so in dark green, you can see that these measures were designed to improve the adult immunization rates for patients enrolled in an MTM program. These complementary draft measures target the rates of immunization assessments and compliance with ACIP recommended vaccines, including influenza, pneumococcal pneumonia, herpes zoster, tetanus, and hepatitis B. Other vaccines were not included because they were recommended with certain limitations. So the first measure on the left is the immunization status assessment within MTM. This measures the percent of individuals 19 years in age or older who were eligible for MTM and received an immunization status assessment during the measurement year. So a higher rate would indicate a better performance. And the intended use is as a monitoring measure for MTM programs. And the second draft measure on the right is the immunization status compliance within MTM. This measures the percentage of immunization status assessments documented as ACIP compliant among individuals 19 years or older who are eligible for MTM. And again, a higher rate would indicate better performance. So all vaccines from the 5 recommendations must be assessed, and an outcome for each vaccine must be documented as ACIP compliant complete, ACIP compliant incomplete, not ACIP compliant, or contraindicated. And so ACIP compliant complete would mean that a patient is compliant with the recommended guidelines. ACIP compliant incomplete would mean a patient perhaps has received 1 or more doses in a series, but has not completed the full series yet. Not ACIP compliant would mean that the patient is not compliant with recommended guidelines. And immunization contraindicated would indicate that the immunization obviously is not indicated for that patient. And so now I'll turn it over to Simon to share more about how these measures were translated into the DocStation platform.
Thanks, Megan.
Mm-hmm.
Let's see if I can advance it to the next slide here. Technical difficulties. There we go. Okay, so DocStation translated these measures developed by PQA and implemented them as a clinical workflow called an immunization screening task. I'll show you guys what that looks like in a minute. But using this immunization screening task, we assess 2 things. And this is going to be familiar because it's a reflection of the measures. The percentage of patients with completed immunization assessments per total eligible patients, and then the percentage of patients in compliance with ACIP recommended immunizations per total number of patients who are assessed. So as to minimize a negative workflow impacts, DocStation only targeted high-risk patients who are at or above a specific med number threshold. That number of meds is lowered based on the length of time that a pharmacy has used the platform in order to sort of disperse their workload and their reimbursement over time. We just don't want a pharmacy joining the platform and immediately having 1,000 tasks to have to deal with. It seems pretty daunting. So we fire an immunization screening task for high-risk patients every 6 months. Again, so as to evenly disperse a pharmacy's workflow or workload over the months. We target a different group of eligible patients, but of similar size for the immunization screening task each month. For example, group 1 might be targeted in January and July. Group 2 is targeted in February and August. So after testing for 10 months, most eligible patients received 2 immunization screening tasks. When this is the case, we reported only the most recent compliance results, which gave pharmacists 6 months to close immunization gaps identified in the first task. Taking a little bit of a step back, I'd like to provide some background on DocStation. So DocStation is a patient care platform that connects pharmacists with patients. We pull in pharmacy and medical claims, dispensing data, and state immunization registry data to create a single sort of source of truth in our patient record. Then we feed that data through a variety of algorithms to identify clinical risk and then serve up patient care opportunities to pharmacists. So we build simple, intuitive clinical workflows called tasks like this immunization screening task for pharmacists to quickly document and then report their encounters so they can spend less time doing manual data entry and more time with their patients. I'm going to have trouble advancing these slides. So this is the immunization screening task that we developed. I'll take you through each step of the workflow so you can better understand how these measures were implemented and how the data was collected. So in step 1, a task is triggered automatically for a patient we identify as being high risk and ends up in the task queue of the pharmacy in which that patient is attributed. DocStation presents the patient's immunization history, some of which is going to be populated automatically by claims. The pharmacist opens the immunization history window to bridge patient record gaps with immunizations that are either reported by the patient, administered in the pharmacy, or identified in the state registry. After updating the patient record, Try that again. The pharmacist selects that they would like to intervene. DocStation asks the pharmacist to use immunization history in CDC immunization guidelines to ascertain compliance status. The pharmacist selects not up to date, or contraindicated for each of the 5 ACIP recommended vaccines. Then after documenting a status for each vaccine, the pharmacist can complete the task. In completing the task, the pharmacist effectively documents an immunization assessment and compliance status for each ACIP recommended vaccine. And in the background, we capture the immunization CVX code, an immunization assessment procedure code, and a corresponding compliance finding for each vaccine. So now we're going to get into the findings. So we have 17,911 total eligible patients. Here is a demographic breakdown of our eligible population. Looking at age groups, we have 3% between 19 and 64. We've got 63% between 65 and 80, and the remaining 34% 81 and older. Looking at gender, we have 41% male and 59% female. It's also important to look at low-income subsidy status, since people who qualify for the Part D low-income subsidy, or the extra help is what it's called, are only responsible for 1 copayment for a vaccine. Thus, we can sort of analyze whether making vaccines more financially accessible improves their compliance rates. Looking at this, sadly, we have a really small sample size for that low-income subsidy group. Only 246, or 1% of our population, were in that group, and then the remaining 99% were in the non-low-income subsidy group. Now, taking a look at the cumulative results for the immunization assessment measure. Again, the denominator in this assessment measure is going to be the number of patients we identify as being high risk and eligible for an immunization screening task. And then the numerator here is the number of patients who have completed the immunization assessment for each vaccine. The data is really consistent across each vaccine group, showing about 99.5% of our eligible members received an immunization assessment for each vaccine. And then on the right, we have the aggregate results. This is going to be 17,816 of our members received an immunization assessment for all 5 of the ACIP recommended vaccines. And this is effectively going to be our denominator for the compliance measure. Next, looking at the aggregate compliance across our demographic groups that we followed, 6.4% of our total eligible population were compliant or up to date with the 5 ACIP recommended vaccines. Looking at age, the 19 to 64 age group demonstrated the highest aggregate compliance with about 9%, while the oldest age group, 81 and above, finished with less than half of that, with 4%. Men achieved 7% aggregate compliance, a touch higher than women at 6%. And the low-income subsidy compliance rates are really all over the place, which is likely due to our small sample size. Now we're looking at the cumulative results for the immunization compliance measure. Again, the denominator here is the number of patients who have the completed immunization assessment for all 5 vaccines, which is the 17,816 patients. The numerator are going to be the number of patients. The numerator here is going to be the number of patients who are compliant among each individual vaccine. So in order here, 28% of eligible patients are compliant with the hepatitis B, 31% are compliant with herpes zoster, 74% are compliant with influenza vaccines, 67% are compliant with pneumococcal vaccines, and then 56 are compliant with tetanus vaccines. Upon further inspection, the compliance rates are fairly consistent across all of our demographics, but we can make a few observations. First, looking at age here, the 19 to 64 age group have higher compliance with the hepatitis B and tetanus vaccines, while our 65 and older age groups have higher compliance with influenza, pneumococcal, and herpes zoster vaccines. Looking at compliance by gender, women actually have a few higher compliance points for all vaccine groups except for tetanus, where men are 3% more compliant. And if you remember from the previous slide, men's aggregate compliance is just a touch higher than women. That's the compliant for all 5 vaccine groups. Here we're looking at a scatter plot of pharmacy patient count and number of completed assessments. To be expected, we see a positive correlation demonstrating that larger, busier pharmacies are also able to keep up with their workload. This is essentially another view of that, a histogram of completed immunization screenings per pharmacy, showing a majority completed between 1 and 51 immunization screening tasks. Our top performing pharmacy completed 493 assessments. 12 of our pharmacies completed over 200 assessments, and 67 of our pharmacies completed over 100. Now, I'll hand it back over to Mel to share a bit about what pharmacists have experienced in implementing the tool in their workflows.
Okay, Mel, 1 second. Let me transfer the keyboard and mouse to you. All right, Mel, it's all yours.
Great. Thank you, Richard, and thank you, Simon. All right. Well, although surveying pharmacists wasn't set forth as an official objective of this work, we're always very, very interested in learning about their experiences throughout the process. So towards the end of our study, we did develop a very brief survey, of course, to minimize impacts on workflow. So I'll share a little bit about that with you now. The survey was composed of just 6 questions. 2 of them were Likert style questions on a 4-point scale from strongly agree to strongly disagree. 3 of them were multi-select questions, and 1 of them was open-ended. And our goal was really to learn a little bit about 5 major areas. The first was usability of the DocStation platform, ability to identify care gaps through this intervention. What were the barriers and challenges to completing immunization assessment that they faced? Also, what tools and resources were they commonly utilized during their assessments? And of course, since this proof of concept initiative did fall during the pandemic, we asked about the impact of COVID-19 on their ability to conduct assessments. We released the survey through the DocStation platform. It was released as an electronic form and was open for several weeks after the close of the study. In terms of analysis, frequencies were reported for Likert and multi-select questions, and general themes and free text entry were reported with representative quotes for the more open-ended questions. So the survey was sent to all of the pharmacies in the study, so all 258 pharmacy locations. And in terms of response rate, we received responses from 66 pharmacists, which represented 46 of those stores. So approximately an 18% response rate. And those respondents represented 4 of the 5 regional chains, and the remainder were from independent stores. So as you'll see in the bar charts here on the right, all of the respondents answered these 2 Likert style questions that we asked. In the bar on the left, we see that, or on the right, sorry, we see that respondents either agree or strongly agree that it was simple to document immunization status within the DocStation platform. And then if you look at the bar on the left, we also see that nearly 90% of the respondents agree or strongly disagree that this task in the platform helped them to identify care gaps. So overall, they reported the platform was easy to use and it helped them to identify care gaps, meaning patients whose immunizations were not compliant with the ACIP recommendations that Megan mentioned earlier. So moving on, as I mentioned, we did have 3 multi-select questions. Each of them had an other option and a request to please describe. Here on the screen, you'll see we inquired about which workflows and resources pharmacists were using to collect and update immunization information for patients. Looking at the bar chart on the left, you'll see, although this project was focused primarily on immunization assessment during a medication therapy management encounter, we were curious about which other workflows pharmacists might be utilizing to conduct these assessments. So as we see here in the chart, not only were they doing it during their MTM encounter, but also during activities like prescription drop-off and pickup, and of course, phone outreach. And then looking at the chart on the right, our intention here was to learn more about the resources that they're using to conduct their assessments. For example, do they access the state immunization registries to identify which vaccines have been reported? Are they using the ACIP guidelines to guide their determination about whether a patient is indeed compliant? And as you'll see across the board, they tended to use all of the tools that we asked about. None of the respondents selected other. I was really hoping they would. I was really curious in learning a little bit more about maybe some unique tools that aren't sort of the common tools that we think of when we're conducting immunization assessments. But when we get to our open-ended question, we did learn a little bit more about some of the other challenges that they faced during the pandemic that kind of indicate that they even do use more than just these methods. So moving on to our third multi-select option, we asked about what barriers or challenges prevented pharmacists from completing their immunization assessment tasks. Again, this option also had an other select option. All of the respondents answered this, and the most commonly reported barriers were time constraints and limited data access to immunization history, which I think we would expect any time in a community pharmacy. But interestingly enough, a quarter of the respondents reported no barriers at all. And then for those who selected other, we see that there were a number of responses. One person replied that some clinics and hospitals don't report to the state registry, making it harder to screen. Only one individual indicated lack of familiarity with the DocStation system itself. And then we also see that this is one of the other methods that I think wasn't teased out in the last question, but sometimes they're waiting on prescribers to respond to vaccination history requests. So that's yet another way that they're trying to obtain this information and get the most full record that they can have. So finally, on our last question about the impact of COVID-19 on their ability to conduct immunization assessments, here we received 63 responses. However, when they responded, oftentimes they cited more than one impact. So that brought the total number of impacts recorded to 70. And after coding each of the impacts, we saw that 3 major themes emerged. So during the pandemic, they either had a decreased ability to conduct assessments for a period of time, typically during the start of the shutdown. They had no impact, or they were faced with some pretty unique challenges that arose. So I'll start at the top of the pyramid here with some of those unique challenges. Of course, we did see time constraints, staffing shortages, workflows cited pretty often in this area. Another one that isn't a surprise, but lack of personal protective equipment supply was a challenge for many. But some of the unique challenges that popped up were that immunizations that are delivered in a series were interrupted. So as we can see here in the quotes, one of the respondents replied that some patients were not able to get a second shingle shot within the recommended 6-month window. And one of the other really unique challenges that had arisen during this time involved patient perceptions. And so you'll see here, some pharmacists were asked, well, how will I know the difference between COVID symptoms and Shingrix side effects? Okay, so moving down, a surprisingly large number of respondents indicated no impact, which aligns with what we were seeing on one of the other slides. So I think this could be, as we saw a couple of slides ago, pharmacists were also using telephone outreach as a mechanism to complete this task. And as you see in the representative quote here, it has not affected our assessments. We are still making calls. And it could also be decreased flow in the store that may have allowed for more calls to be made during that time. Finally, we did see quite a number respond that it decreased their ability, and particularly during the start of the shutdown, there were quite a few responses in that area. Several of the pharmacists replied that they had paused immunizations during the first couple months, and so they also stopped conducting immunization assessments. And some of the reasoning for that here is in these quotes as well. So you'll see on the last one on the page, it is challenging to provide an immunization assessment when patients are hesitant to come to the pharmacy to actually receive the recommended vaccines. They may forget about the recommendation. So we did see that a lot of individuals were just putting that on pause for a little bit and setting reminders in their systems. So some really interesting stuff came out of that survey. But before we get to the discussion and the Q&A, which is my most favorite time, I'll share just a few of the implications and limitations to our proof of concept study. First, with the limitations, as I reflect on some of these limitations, I see a lot of opportunity. For example, the first here is generalizability. You'll see, or as we've talked, you'll see that this was conducted using one platform. It was with regional and independent community pharmacies only. It was one health plan, and it was in one region of the United States. So again, a lot of opportunity here to scale to more platforms, different community pharmacy types, additional health plans, and even broader within the United States as well. So I see a lot of opportunity there. The second limitation is that gap closure was not captured specifically. So we looked at assessments that were conducted, and then we documented compliance. But as we've talked over the course of this study, it would be a fairly easy build to build out, okay, well then what did you do? So that we can see what types of interventions may be increasing rates as we move forward to close those gaps. And then last here, we didn't have a way to ensure that all pharmacists and all stores receive the same training. And that could be training in terms of how to use the tool or how to assess complex immunization status like pneumococcal compliance. So that's definitely, again, another opportunity for us as we move forward. So as we've seen over the course of Megan sharing in the beginning and Simon, and then just this wrap up here, we feel this proof of study does provide the proof of concept that these data can be meaningfully captured in an EHR. And we're seeing that pharmacists are already actively conducting these assessments, and they're quite active in that space. So having a standardized method to capture this information in an actionable manner really allows us to do a number of things. Like I talked about on the last slide, when we identify the gaps in immunization status, we can target our outreach and quality improvement efforts. We can look at specific, as you saw, when we're not looking at the composite level, when we're not looking at all 5 at the same time, and we're looking at individual ones, they have various compliance rates. So we can target our quality improvement efforts to where we can have the biggest impact. Also, when we have a standardized method for collecting and reporting the data across different business types and different platforms, it will allow us to create standardized ways to measure performance there. And I guess I'll just leave it on something that I found really interesting before I turn it over to Richard to curate the Q&A session. But you will have noticed when Simon was reporting out the results that when we looked at the aggregate compliance or compliance to all 5 of those vaccines, we saw that the rates were really very low. It was 6.4%, he reported. And so I got a little curious, and I found in the literature that for composite measures like this, we are finding very low rates across different practice types, including provider settings, anywhere from 6.3% to 13.7%. So I think that gives us a lot of other things to think about as we move into the future in terms of what is meaningful to measure, what creates an actionable next step in terms of whether we measure it as a composite, which one should be in that composite, or whether they're measured all separately. So I'll end there, and I'll pause and turn it over to Richard. I'm sure we have all kinds of questions and answers. I know I did as I was moving through this, but Richard, over to you.
All right, well, thank you, Mel, and thank you to Simon and Megan as well. It's been a really informative and detailed explanation of how pharmacists could play a greater role in improving immunization rates. We do have a number of questions, so I will go through those now. And some of these you may have covered over the course of the presentation, but I think it may be a good opportunity to kind of, elevate some of the important points that you've covered. So a first question, is this data also synced with the state registry, or would they have to look up the patient in the state registry separately?
I'll take that one. So in a few of our states, not all 7 of these states, we do have state immunization registry integrations. So in those states, we're directly synced with the state immunization registry. I'm sure many people know, this data is not, not all pharmacies report to the state registry, so this data is not perfect. And then obviously in the states that we don't have these integrations set up yet, they're accessing the state registry manually outside of the confines of DocStation.
All right, thank you, Simon. And just a reminder, if you have additional questions, you can use the question box in the platform control panel to submit those now. Our next question, how were the vaccines selected? There are additional recommended vaccinations for adults.
So to their point, they're absolutely correct. There are other vaccines that are recommended for adults, but they were not included because they were recommended with certain limitations. And so we looked at the ACIP recommended vaccines for those 5.
Okay. All right, our next question, how are you accounting for patients that have been immunized as part of their inpatient stay, but are not reported through standard means, such as claims? Likewise, there are some gaps where ambulatory provider vaccine administration are underreported, particularly in adults, because they do not submit the claim appropriately, and the reimbursement margin overall is low, and the opportunity lost is under-recognized.
Right, really good question. We really rely on our pharmacists. So in this case, they can only report as well, or document as well as what's been reported in the past. So they're maintaining a really close relationship with other providers involved in the patient's care, as well as the state registry and the patients themselves. And we really rely on them to use all of that information to document the most accurate immunization history that they can. And there's going to be improvements in this recording in the future, but it's not nowhere near perfect right now.
If a program is not using DocStation or another vendor that captures this information, are the 2 immunization measures based on self-reporting?
So Richard, can you please repeat the first part of that question?
Correct. If a program is not using DocStation or another vendor that captures this information, are the immunization measures based on self-reporting?
So I'll just offer a little bit of an answer here. I'm not sure what that would look like in terms of an alternate program, but I would say that the measure itself does inherently have a bit of self-report. As we saw, the ways that pharmacists were collecting this information, although they had a DocStation platform and they were doing it through this program that we had initiated, they were relying on not just state immunization registries, but also talking to people about their records. So there is that component of self-report in it. I'm not sure that that fully answers the question, but at least it does offer, I think, sort of a broad view of all the ways in which pharmacists were trying to capture that information.
Yeah, and to add on to what Mel said, we're excited about the results of this proof of concept and are excited, right, to test this in other platforms as well.
And related to this tool, are pharmacists able to document the vaccines they've administered in this tool?
Yep, exactly. In the first part, if you remember, in looking at the immunization history, in that sort of panel, pharmacists can add any immunizations that were administered in their own pharmacy, or any ones that the patient happens to report, or ones that they identify in the state registry that aren't reflected in the immunization history. We're hooked up with the standard immunization library of codes, so we can really allow pharmacists to document anything that exists out there.
Okay. So in the presentation, there were gaps identified among the 5 vaccines. Can you share more your thinking on why those gaps exist?
I'm sorry, Richard, can you repeat that?
Yeah, just there's a request for you kind of hypothesize further on the differences in the gaps between the 5 vaccines in terms of completion rate or administration.
Sure. Would that be in reference to the assessment measure or the compliance measure?
Well, it didn't specify. Could you address both?
And I guess the difference in the numbers in the assessment measure, there's a tiny amount of difference. It's about 99.5% across the board. I think from what I've heard from our engineers, that's based on some anomaly with how the task is documented. But in general, pharmacists have to complete an assessment and determine compliance for each vaccine in order to complete the immunization screening task at all. So the results aren't recorded unless the task is completed. As far as the compliance measure goes, I would think that just it's due to the nature of each vaccine themselves. But yeah, I couldn't make any more specific speculation on that.
No, I think it's a great question. We also need to take into consideration that these data were collected in part during a pandemic. And as Mel pointed out, several of the pharmacists did say they had a kind of decreased ability. Patients were kind of nervous to come back to the pharmacy. So I think there's a lot going on there, and it's important to unpack that. It's a really good question.
So we have an additional question about data capture and output. Can the data be used and analyzed either by pharmacies or third parties to identify community gaps at a higher level?
Yeah, certainly. So our goal really is to record in doing this, not only in implementing these measures, but is to improve the immunization registry data or immunization data in general for our patients. So by completing these tasks, our pharmacists record the most accurate reflection of a patient's history that they can. And then in the future, we want to push this back to every state registry in the United States. So we know what those gaps are, and anybody can access them no matter where they are.
We received a comment that noted that some payers are reluctant to use any of the immunization measures in value-based reimbursement programs because of the data gaps. Can you talk about the implications around that?
Sure, I think, oh, sorry, I don't know if somebody else was trying to chime in, but I'll be quick. I think, we have to do it to address those gaps somehow, some way. So we got to start somewhere.
And I'll just add to that I think this gives us a perfect example of how we can capture this information on the pharmacy level and standardize that. We have so many different platforms that are being used across community pharmacy. I think this provides a lot of opportunity for us to dig into how we can meaningfully measure performance at the pharmacy level, and then how that can be used in those value-based agreements. I don't think we dug too much into it in our discussion, but and maybe Simon can speak a little bit to this, but their team did standardize on the back end the SNOMED codes and the RX norm codes and all of those things. I don't know if you want to add on to that, Simon.
Right. Yep. Oh, go ahead.
No, go ahead, Simon.
Yeah. So our entire system is built to be interoperable using these SNOMED codes, these CVX codes, if you guys remember mentioning those. So by creating a documentation workflow that utilizes these codes and having an interoperable system, we're ready to integrate with any system out there. If our patient gets admitted to the hospital, next week, or a patient that fills at a pharmacy that uses DocStation gets admitted to the hospital down the street that uses Epic, when Epic is ready, we can integrate with them, and so they can know what immunizations the patient's gotten in the past, and really what anything that's been documented in DocStation for that patient in the past.
So Simon, somewhat of a follow-on regarding interoperability. Is DocStation connected to any health information exchanges?
That's not in my wheelhouse, so I couldn't make any stabs at that. Would like a state immunization registry qualify as that, or is it something a lot larger than that?
Well, it's a good question. I don't have a qualifier for that. Do you want to say a little bit more about the state registry connection?
Right. So we, in creating this single source of truth for patient records, our goal is to integrate with every health registry out there. So this is state immunization registries. This is obviously claims data. This is in the future going to be laboratories to bring in lab data. Any source that we can use, and then dispensing systems as well, obviously. Any source that we can use to better reflect that patient's health history, we want to. We're interested in that.
All right, thank you, Simon. I've had a qualifying comment come in relation to that. Just noting that some states have a single HIE, while others regulate what should be exchanged, but there may be multiple HIEs.
Sorry, I don't know enough about it to answer the question.
Okay. All right. So a question about the survey design. Did pharmacies get paid to complete the immunization screening tasks? If so, who was the payer? Was it the project funder, or was it, you know, a particular health plan?
The payer was a particular health plan. I can't say who it was because we have an NDA, but we ran this program as it's a per member per month EMTM program. So our pharmacies were reimbursed by the percentage of tasks that they completed each month. This immunization screening task is just one of several that we employ.
And to speak to the survey aspect, we did not incentivize pharmacists to fill out that survey, and the support for the project was not used to incentivize pharmacists to participate, to my knowledge.
Yep, that's correct. They weren't incentivized for the survey itself.
Right.
All right, thank you, Mel, for that additional comment. And that, I think, leads me into the last question I have in the queue for now, and it has to do with the survey. In surveying pharmacists, did you receive any specific feedback regarding areas for improvement for the tool, or did any pharmacists kind of disagree with how to, or the ability to identify gaps and kind of just areas for improvement there?
Good question. You know, when we put the survey together, of course, it was like 3 pages long to start. But, you know, we want to know everything under the sun. We're really excited to learn about their experiences. So when it came down to usability of the platform, I know that DocStation has several different avenues that they can learn a lot more about that. So we kept those questions fairly limited and Likert style only. And we received very few responses that it was difficult or challenging to complete the task, which was really promising. Outside of that, no specifics. We really didn't have an open-ended question around that. Simon, did you want to speak to any of the other ways that you sort of learn about your pharmacist experience with your platform to round us out?
Really, outside of surveys, it's just being in direct communication with our pharmacists. We have a chat service that's integrated in the platform, so pharmacists can pop in and sometimes say hi, but most of the time ask questions. And so we maintain really close communication with them, and you know, we really rely on them and their feedback for where we go with the platform, how we make improvements, and what we change.
All right, well, thank you, Simon. Well, we are nearing the top of the hour. I want to provide a quick reminder that the PQA Leadership Summit takes place 3 weeks from today on Thursday, November 5th. Registration is free to all PQA members. Visit our website and check your emails for more details. In closing, I want to thank again our sponsor for today's event, PerformRx. I want to thank our speakers, Simon, Mel, and Megan, and thank you to our audience. It's been a great dialogue. We've had a lot of really thoughtful questions. If you have additional questions, feel free to reach out to us at info@pqaalliance.org, and we can get your questions to today's presenters. Again, today's event is being recorded, and a copy of the recording and slides will be available in the Member Resources Library later today. To stay on top of PQA news and events, please follow us on social media. And as you leave today's forum, there's a short survey about today's event and what you would like to see in future forums. So thank you again for joining us. Have a great afternoon and goodbye.
Thanks, everyone.